welcome after 4th of July. Welcome, welcome back. Welcome to blackdoctor.org, where wellness and culture connect. I'm Dr. Cordai Decoto, board certified podiatrist for Neighborhood Health, a qualified health center in New Jersey, providing care for all, regardless of immigration status or insurance. I am also the co-founder of Sisters in Podiatry, a Facebook focus group for Black women in podiatry within the United States and the Caribbean, and your host always of the premier show, Stepping Forward with Dr. D, your gateway to all things in podiatry. So grab your favorite beverage and get ready because we're ready to start and spill some tea. And I'd like to introduce my first guest. My first guest is a good friend of mine because, hey, all things podiatry, we are connected. And I'm so pleased to introduce Dr. Jacqueline Sutera.
Hi there.
Hi. So Dr. Jacqueline Sutera believes in a holistic approach to foot care, guiding patients at City Podiatry in where? Midtown Manhattan, ladies and gentlemen, to discoveries that are related to every part of the body, not just the foot. She practices also in my state, Northern New Jersey, and is an attending at Hackensack University Medical Center at Passaic Valley. She graduated from Fordham University in the Boogie Down Bronx, where she received her bachelor's degree in biology and philosophy and got her medical degree at my alma mater, the New York College of Podiatric Medicine in Manhattan. She performed her residency at Jamaica Hospital Center in Queens, where she was a chief resident. She is board certified, specializes in women foot care, giving her patients the opportunity to talk through their ailments and help them understand how podiatric issues relate to overall health. She's one of New York and New Jersey's most trusted experts in the industry and has appeared in many national news outlets discussing and writing about foot care. She approaches her practice with compassion, conscientiousness, and unique, wide-ranging base of knowledge and experience. Welcome, Dr. Jacqueline Sutera.
Thank you so much.
And my next guest, I'm proud to bring to us as well, which is a friend, Dr. Bijou Nafour.
Hi.
So Dr. Bijou Nafour is a graduate from NYCPM, the New York College of Podiatric Medicine, like all of us, in 2008. She trained at Montefiore, which I was one of her attendings, and she was absolutely wonderful. She's in private practice in Mount Vernon and in Yonkers. She specializes in podiatry of the foot and ankle surgery for all. She's affiliated with St. Joseph's Medical Center, which she does wound care for some of our patients who have these wounds that simply won't heal. I welcome Dr. Bijou Nafour.
Thank you. Thank you for having
So
me.
it's so great to have you two because I know you personally and it makes it so much fun. And people, we want to know, as always, where are you coming from? Where are you? I'm in Northern New Jersey. Dr. Sutera is in Northern New Jersey. Dr. Nafour is in New York. Please put in your comments where you're hailing from. We always give special props to everybody when I see the comments. I'm going to give a special shout out to some friends I know who are watching in Brooklyn, BK all day. Thank you so much. And we appreciate all the support that we get. So, Dr. Nafour, you were one of my residents back in the day. Woo! I feel old. I'm trying to keep it together. But I recall you being wonderful and our training at St. Barnabas Hospital in the Bronx. We were under Dr. Emilio Goez. So thank you, Dr. Goez, if he's watching, and for his support, and to St. Barnabas in the Bronx. So Dr. Nafour, tell us a little bit more about your practice, and then Dr. Sutera, I'm going to ask you the same question, and then we'll get into some of the nitty-gritty.
Okay. So I'm based in Mount Vernon, where my primary care, practice is, and also at Yonkers. I practice also at the wound center at St. Joseph Hospital, where we heal chronic wounds, and then also hyperbaric treatment for patients who have complex wounds. And we try to treat them very well. So my practice consists of everything from little children all the way to adults. I do very many different types of procedures, surgical, wound, laser treatment. So that's basically what I do. And I let my patients speak for me. And I'm very passionate when it comes to the treatment of foot ailment, because I try to let the patients know what is the importance of having the feet and how to take good care of them. And podiatry has been that branch where we get to find so many different illnesses that patients have. We are the first one to diagnose quite a few illnesses before
Absolutely.
they get to other doctors. So I try to educate them as much as about their bodies and what are the different problems that can be associated with their feet, and we can be able to treat what is related to.
Absolutely. And now I want to say, yes, I see the shout out in the comments. Yes, I see Fort Worth, Texas. Yes, we see you, Jairus. I see the grand girls, Demaya and Dream in Georgia. We say hello back. I see Kelly in Baltimore. We love the DMV. Welcome, welcome, welcome. Everybody keep giving us a shout where you're from. We would definitely shout you out. Dr. Sutera, my girl, Jackie, tell me about your practice.
Well, I can't believe it's been already about 21 years that I'm in private practice. Okay, I'm dating myself too. I still consider myself one of the younger practitioners, but it's been a while. It's been 21 years. 21 years of part-time in Manhattan and part-time in New Jersey. So I spend part of my week in Manhattan and the other part in northern New Jersey. I'm an attending at Hackensack University Medical Center at Pascack Valley. We have a private practice there that's also very, it's a multi-specialty practice. So I spend my time surrounded by wonderful doctors. I think there's about 20 of us in New Jersey, where there's an endocrinologist and a cardiologist and primary care, and we all refer to each other and trust each other. And it's just been wonderful. Not so many people that I know can say that their partnerships have lasted this long, and like how much we actually admire and trust each other. So my multi-specialty practice is really special to me because we have this great bond and this great trust, and we take really good care of patients. And then my little boutique practice that's a lot smaller and just private, and it's only podiatry in Manhattan, also very special in a different way. There it's just podiatrists, but we've been together for my whole entire career. Like, I finished residency on June 30th, and July 1st I started with this practice, and I've been with them ever since. So I really enjoy my career. I enjoy what I do. I think that it's just been wonderful, and I hope to do it forever. I'm not looking to retire anytime soon, nor can I.
I understand, my love. Hey, we're all practicing. And yes, we
Yeah.
see you, Clifton, New Jersey. That's near me. Yes, Barbara, thank you for watching. So, Hammer Time. I mean, I have had so many jokes about Hammertoes. You know, I'm going to date myself. When MC Hammer came out, that was the joke. They used to say, Hammer Time.
Right.
For those who are probably under 30, they're probably like, this corny doctor. But yes, those above 35, 40, remember that. So, I'm going to ask you, Dr. Nafour, what is a hammer toe? And give it to us in layman terms. Remember, this is not for doctors. This is for the community. So we're going to make sure that we understand that, because so many people talk about they corns, and they don't understand that usually corns come from hammer toe. So give us a description of what a hammer toe is.
So a hammer toe is when you're having stiffness in the joint, in the toes. Basically, we call it sometimes cricket toe. People come like, my toe seems to be bent at one joint, and in medical term, we call it contracture of your joint. So basically, the toe consists, I have actually a bone here. The toe consists of...
Always the perpetual student. I love it.
That's right. So
you
this
notice Jackie
is
and I are
toe,
like,
basically, I'm going to turn it to this way. So the toe consists of this joint. This is the big toe, but the smaller toe are the one that are affected by the hammer toes. So basically, one of these toes right here, this joint gets bent down like this. Therefore, it leads to friction, meaning pressure in the shoes, and start rubbing against your shoes. And that's where you start developing corn. And then that can cause a lot of pain. And sometimes patients who are diabetic, they can end up having ulceration, which is wound on their area, and that can cause them to have tremendous problem. And then we do have two different joints, and this side of the joint, which is the very distal part, which is the front part, that can also be bent. But we have different terminologies for those. We have what we call hammertoes, we have mallet toe, and then we have claw toe. So when one joint is affected, which is this joint, we call that a hammertoe. When it's only at this joint, we call that a mallet toe. And when it gets both joints affected, we call that a claw toe. But we
Absolutely.
categorize all of them as a hammer toe most of the time.
Absolutely. So hammer time. Dun, dun, dun. So I see Renee. Hey, Renee from Passaic. We love Jersey. Thank you for watching the show. Dr. Sutera, Jackie. So she described what hammer toes are. So now y'all know that y'all got some bent up toes, okay? And we see some of these stupid commercials on Amazon. You can buy a toe straightener, and this will make your toe. Tell us, Dr. Sutera, what are some of tell me what typical patient you see in the office and some of the things that you say to them.
I see different types of patients, right? Two mainly, I'll just speak on two. One is with a flexible type of hammer toe where the toe can actually still bend, but in its relaxed position, it's a little contracted. The other is when it's a very stiff toe in that contracted position that doesn't really bend, or that bends a small amount and it's super painful. Usually those are associated with like arthritic conditions and much more like later in life, or even after trauma sometimes. Mm-hmm. So with the different types of hammer toes, you know, in my practice, I have a very individualized type of care plan for each of those patients, and it's not a one size fits all. So what I like to do is really assess the patient, the types of shoes that they wear, the types of activity that they do, and also where they are in their life. If they have a flexible hammer toe and it's painful, then we can do an arthroplasty. An arthroplasty is when we remove a small portion of the affected knuckle, and that relaxes it so that you can sew it straight and be on your way. If it's a crooked and very stiff and arthritic joint, I tend to like to do an arthrodesis. Arthrodesis is where we actually fuse the knuckle. So we remove that little portion, that's that contracture, and then we fuse it together. So I say to my patients in a cute way, I'm going to trade you a stiff crooked toe for a stiff straight toe. So that's like one of the decisions that as a surgeon, I feel like I have to make when it's time to talk about different surgical procedures for hammer toes, whether I'm going to do an arthrodesis or an arthroplasty. And that's in general what makes me decide one way versus the other, whether there's flexibility or if it's like stiff and straight. You know, there's conservative treatments also. And before we jump to surgery, we should always try a lot of conservative treatments. A lot of these little gadgets that you just referred to.
Amazon,
I tell patients, I don't think that a lot of them can hurt really, but they're not really helping. They're not going to help you to like reverse what you got. When the bone and the toe is in this position, it's really not going to make it straight again. It might help to keep things loose and limber. It might help to just feel good because you're being stretched out, in which case go ahead and use it. I wouldn't spend a lot of money. And also don't expect that this thing is going to reverse your hammer toe. But Absolutely. Make sure that you're wearing shoes that are accommodative. Make sure that you're wearing shoes that are not contributing to the problem. So nothing stiff, pointy, narrow. You want to stay away from that. You want to also make sure that the toe box in your shoes has enough room for all of that.
That means height of your shoe. People think, oh, I'm going to go a size bigger. That doesn't necessarily help you if your Correct. Toes are like that. The height, sometimes we have those narrow ballet flats, and the height is what's rubbing and aggravating the top of your foot.
Correct. Yeah. So conservative treatment first, and then when it's time, you know, there's great surgical procedures for hammer toes.
Absolutely. All right. Shout out to one of my dear friends is on, the Schumer Pemberton. We see you from the DMV in the house. Chris, we see you, Massachusetts. Carolyn, Greensboro, Alabama. Welcome, welcome. Lanice from Florida. I grew up in Florida. Yay. Welcome. When somebody's saying hi to Dr. Nafor Delam, watching in Connecticut. Thank you so much. So I'm going to chime in. I have patients who will come. I've been in private practice. I've been in multidisciplinary practice, and now for a federally qualified health center. And we get these corns sometimes on the top of our toes. And I will be honest, I was a hammer toe patient. I was like, not me. I'm too cute for that. And while I was in school at NYCPM, I had my pinky toe had this horrible callus corn on it. I remember dating myself to when the World Trade Center prior to 9/11. I was walking in there and I remember it hurt so bad. It was snowing. And I told one of my good friends, I'm gonna walk in the snow. I don't even care. That's how bad it was. Conservative treatment, I had an injection, which helped for a while. I had some of the padding, some of the things that you may see at your local pharmacy, moleskin and hammertoe pads. I did not try any of the acids. Those acids, particularly if you have poor circulation and or diabetic, can cause a wound or an opening that becomes a whole problem. So please don't think that hammertoe removal acid works. It does not. And then eventually I said, let's fix this. And I had my two of my professors, Dr. Mandado and Dr. Fahim, they themselves back with one of my friends, Mike, who did the surgery for me. And I did it in the office. So I was conscious for it. And I was a new person, night and day. I also had a fourth toe done when I was in private practice. And my good friend, Dr. Brian Butts, did it. And I was a year ahead of him. So I was bossy. I hope you're doing this and I hope you're doing that. My even though I had taken some meds to relax me, it didn't relax me till later. So conservative care, yes. There's some patients, as we know, just can't do surgery. Diabetes, y'all not eating right. It's just not well controlled, where your hemoglobin A1C, your doctor checks, is going to say that, ooh, and we'll look at it like, you may not heal. You may have very poor circulation. You may not be a candidate for that either. But let's talk about, I'm going to ask both of you, let's talk about the diabetic patient versus the healthy patient, because there's sometimes we do different things. So I'm going to go back to Dr. Sutera for a minute and a concise answer to the both of you. You have a diabetic patient. The diabetic patient complains that their toe, I'll use my finger, hurts. You see a callus there. You cut down the callus. We call that debriding it. And we see that, ooh, there might be a wound underneath there. Tell us, Dr. Sutera, walk us through that. And Dr. Nafoor, tell me some of the things that you would do as well. Dr. Sutera?
Well, I think you will both agree that with diabetic patients, we have to be pretty stern. And part of our job is to scare them straight, no pun intended with the straight toe. But when I have a patient like what you just described that's diabetic and has this potential like ticking time bomb, and it's time, in my opinion, to take care of it, I say to them, hey, do you want to do like an elective, cute little hammer toe procedure and make this toe straight so that it's not a problem? Or do we want to wait until it turns into a real big mess and then risk losing the toe, losing the foot, losing your leg? Because that is a reality. So that's when I get real pushy with them. Of course, you have to make sure that they can heal from the surgery. You have to make sure that they're not smoking and their A1C, like you mentioned, all those ducks have to be in a row. But it comes down to that. I give them the choice.
Hold on one second. I'm going to interrupt you for 1 second.
Yeah, sure.
The smoking. People are listening to us and go, We don't mean smoking cigarettes. We mean smoking anything. The body, I'm not here to judge anybody who smokes marijuana. It's legal in New Jersey and New York. But the burning process affects your circulation, especially your very tiny circulation in your toes. And so what may be good for one thing may affect your circulation somewhere else, which then prevents us from doing our job and having to get our vascular colleagues involved to get blood flow in your foot. So keep that in mind. Continue, Dr. Sutera.
Yeah, so really it comes down to that. Like, I'll just kind of sum it up. Do you want to have a small little elective procedure now, or do you want to try to save your leg and your foot and your life later? Because I do see hammertoes with these corns that are potential ulcers and wounds being a problem later on. And I've certainly over my career amputated more toes than, I'd like to admit, unfortunately. But it's a choice. We have to save the foot. We have to save the leg. And these toes become a real problem, especially because those vessels are super small at the bottom of the foot.
Absolutely. Dr. Nafoor, tell us some of the things that you see when you tell your diabetic patients who may present with the same thing.
So it's basically the same thing I tell them. And the first thing is, especially if there is a wound, I tell them for the proper wound care, which is not to get the foot wet. Because once we take that one layer off, you're now opening the wound and you leading to, I'm trying to say it in a way that people can understand, you're causing like an introduction for bacteria that we have on our body to go. So once you take a shower, the water from your body can penetrate, go inside of that area where you have the irritation or you have a tiny little wound. And before you look, that's being infected. And then this is how most of the diabetics, especially those who have very poor circulation, could end up with gangrene and end up losing their toes. So basically, if they have a flexible, like a hammertoe type, like she described it before, instead of causing them to have, like the wound from getting bigger, I will prefer to do a small little percutaneous sternotomy, which is like we go in there from the bottom of the toe and we cut the very tendon that's like closer to that toe at the front, and we cut that to take from being this way from it stretching up a little bit. Therefore, that would take the pressure off, and then I wrap them up, and then I tell them to keep it nice and clean so that there is no infection. But I emphasize in changing the shoe gear as well, because that's the key. If there is any pressure, then we're going to have bigger wound, and therefore shoe gear is the proper thing. But first of all, keep the foot area, the wound area, dry and clean. I say if you see any lesion, any kind of opening on your toe, call the office, come immediately so that we can treat you, because we allow emergency cases to come in the office right away.
So I'm going to switch to now the healthy patients. And you just said a bad word. Now, I know my friends are watching who wear their Louis Vuittons to their Target heels. They're not trying to hear that. I have some friends who are diehard, as I'm sure you do too, the 3 and 4 inch wearers, high heel wearers, the cute narrow toes, shoes. And they're like, and so they look, I sometimes people are looking for procedures to get their toes into those types of shoes. I'll comment and then I'll throw it back to you guys. I have been published for my cosmetic incisions. I do interdigital or inside the toe, so I hide your scars, and which particularly on people of color who tend to scar more aggressively or have keloids or even thickened scars, and just women in general and men too these days who are like, I want my toes cute in my sandals and now I have this big scar on top. That's an option that I give. And Dr. Yolanda Ragland had talked about in my previous show about her tiara toe, which she is trademarked as well. So Dr. Nafour, in a couple of phrases, tell us, so now you have a healthy patient. Let's say you have 30, 40-year-old, even 50-year-old, because that's not old anymore. We, 50s, we look good. Great health, no issues. 2 toes, it hurts. Oh my gosh, doc, these corns are killing me. And now I want to go and get this. What can I do? I'm interested in surgery, but conservative care, what does that look like for me? What are you going to do? Go ahead, Dr. DeVore.
Are you asking if they want to do surgery or conservative care?
Both. What options?
Okay.
I share both with my patients and let them know. So tell me what you would say.
So again, we did talk about the shoes. So I tell them how to wear their shoes, like telling them, I'm not saying that you can't wear your shoes. You love your shoes, but we have other patterns that we can utilize for them to wear these shoes. This is the conservative aspect of it. So which can include like silicone thing that we can put on around the toe in the shoes to keep the shoes more comfortable. Or I tell them, if you're getting shoes, make sure that the shoes have a little bit of soft interface inside so that there is not a lot of friction and to allow you. And then I also teach the women who are wearing these designer shoes to try to get maybe like half size, little bigger, so that they don't have all the toes bunched up at the front and they're leaving some space, so that put cottons or some, like a little cushion in the front to take that pressure off, and therefore your toes will be a little bit free and you're not having them bunched up. And then we come to the surgical treatment. So as we said, it depends on what type of hammertoes we're dealing with. Are we dealing with a more flexible one versus a rigid one, which is stiff and is not budging? There is no movement at the joint. So if it is just a flexible one, we can do the tenotomy like I explained earlier, and we can do arthroplasty, as Dr. Satora said it earlier, which is taking the joint off and making it flatter, and therefore that's easier. And then we can do also what we call arthrodesis, joint fusing the whole joint. And sometimes we do that, which I did also research when we were in residency program. We can put implants in the area to mimic the curvature, right? The curvature to allow you to still have that little bend, is not standing, sticking up, straight up, because sometimes the toe can deviate in different position if you're not trying to have a good fixation. So we can also do that. And these are some of the options that I give to my patients.
Thank you. Dr. Sutera, okay, and you're in Manhattan. So we
I'm
know
in
that
Manhattan.
sometimes, we have patients who probably are a little bit more demanding because of the type of work where you are, Wall Street and things of that nature, where they may be required to wear shoes, different professionals. So tell me what you tell your patients.
Well, just to kind of add to what Bijou was saying, because I totally agree. I think my algorithm is pretty similar. But I spend a lot of time talking to them about reoccurrence, right? So yeah, we can go ahead and fix your hammer toes, but 5 years, 6 months from now, if you continue to do what you're doing, our bodies are programmed. We might actually go back and the hammer toe can reform. You can start to regrow some bone. So that is an important thing that I need to go over with my patients before we get involved in surgery, especially with these fancy Manhattan people. Yeah. The other thing
New York
is,
City.
I know, love my New York City. The other thing is moderation and variety, right? And lately I've been talking about my 80-20 rule. And so 80-20, 80% of the time, we should try to be conservative and also be like foot and body loving, so that 20% of the time you can cheat a little bit. A special event, a work party, a date, a wedding, vacation, whatever, right? So do we really need to commute from your house all the way to your office in a 3, 4, 5-inch heel? Do you need to do that? No, you don't. We're not Kim Kardashian. We're not being followed by paparazzi and cameras. So why not take that opportunity and not have so much wear and tear on your body, especially in your 30s, 40s, 50s. In your 20s, these girls are not hearing it at all, and we're invincible. But at this point, we do need to talk about variety of shoes, moderation of heel heights, switching it up. And I definitely would say save your fancy stuff for the look, for when you really need to. Those are things that I just kind of wanted to elaborate on.
I think that's fantastic. I tell patients, particularly when I used to practice in the city, the subway, we don't want you to go flying. That's
right.
Dangerous for those who do that. I said, put on, a cute sneaker, find something that you like and put that on, and then later do what you need to do. So I fully agree. Let's talk about implants. So I'll mention some of the companies, but I am a Stryker girl. But there's also a great product, Osteofiber, which is a type of implant. Arthrex has company. There's just so many. Osteomed has a fantastic implant. There's so many that are on the market. We can, giving you the big names we don't need because it means nothing to the public, to the podiatrist. Everybody recognizes those companies. So Dr. Sutera, Jackie, tell me, I know I'll talk about what I do and then go, I like, if it's a flexible, meaning that the toes like that, no implants necessary sometimes.
Agree.
I just do a tenotomy and splint the toe. Now, if we have what's called, it's semi-contracted, meaning I can get it down, but it's still contracted, and then the rigid contracture where that little bad boy is going nowhere. I have used wires, which are removable. Some patients tell me, I don't want anything in my toe. It just makes them crazy. And we'll use wires that are removable, known as Kirschner or K wires, and they stick out the toe. And then you remove them in the office. I have used implants from Stryker. I've done Arthrex. I've done Osteomed, and those stay in the toe permanently. Which of what I will do depends on the deformity. It depends on the patient's desire of what they understand and what they want to feel. Sometimes implants, depending, now they make them somewhat curved, but in the past made the toes very straight and looked very unnatural. They were like this, and the toe has a natural curve to it. the better implants, as things are moving and grooving and we're learning more, have changed to have what's called a flexure, or there's a degree of where it kind of curves, so it mimics the original toe. So I'm great with that. I can do it from my cosmetic incision, because as again, I deal with a lot of women and men, and definitely people of color who we want to preserve, scarring on the top of their foot. So that's what I do. Bandage your toes quite straight. And, we do x-rays obviously in the operating room. And as you're healing and you're in that little post-operative shoe or boot that some of you guys hate, until we say you're ready to come out of it. So that was a little overview of me. Ladies, and you can both talk back and forth. This is fun. Tell me what you guys do. If I'm coming to you and I'm like, "Ooh, this toe," what are you going to do to me?
I've used all that stuff. Lately, I've been using a lot more of the absorbable pins. I do like the idea. Yes, I do like the idea of that just resorbing over time. The downfall, the con is that there's a little bit more swelling. So patients have to kind of go through like a little bit more swelling. But I like it. I like that it's absorbing and that it's a little bit more of like a natural type of device versus like the metals from the past. So
or any type of polymer meaning that it's a mix of different products that stay in the body. So keep that in mind. I mean, I love all the implants. I think,
and good old K-wires. What's wrong with that?
Yeah.
Love it.
Especially for patients who don't want an implant, it's always an option, because I feel like we should be transparent with your patients. And I tell people, you're part of the decision. If it's being explained well to you, you're the decision. If we tell you we can't do something, then we simply can't. But if you have options and you know what to expect, I think the patient is a big part of the decision of what we use.
Absolutely.
You?
Yeah. So when it comes, I basically do the same thing you guys were talking about, but also I try to make the patient understand about the type of bone we're dealing with, because it's not everybody who is candidate to receiving implants. So like we talked about, if somebody, maybe like your patients who are like immunocompromised, for example, right? You don't want to start putting foreign bodies into their body, and that will cause them to have more problems. So I try to discuss those things to the patients before I proceed. And therefore, those who also have osteoporosis, and you definitely don't want to put any implants in.
Osteoporosis being weak bone, for anybody who doesn't know what it is. Weak bone.
Weak bone. So you don't want to use any implant for those patients, because it's going to fail, and therefore, or the bone is going to shatter, and now you have a bigger problem to resolve. So basically, and also my people of color, I am very careful about using absorbable anything on them, because we end up having more hydrolysis than the
English
Caucasian.
hydrolysis, that's a big word.
Yeah, more swelling, and then they can develop also more scarring. So, and basically, there's certain things that I stay away from, and then I prep my patient depending on the skin tone and the age and everything, and the quality of the bone.
I agree with that. I have used Orthozorb, love it. I don't use it in a lot of patients of color either. Biggest thing that we worry about in people of color is scarring and then swelling. All black does crack, unfortunately. And if you are immunocompromised, then it is, something to be considered. I'd be like, you know what, this may not work on you. I'm putting it in my consent. I have a 4-page consent. My patients laugh like, this is the Bible. That's right. But I want you to understand exactly what we're getting into. For patients like that you're talking about, that sometimes I prefer the permanent implants if they choose to do an implant. And if not, then again, we're back at the good old fashioned K-wires, Jackie said. So I believe in that. Giving a little shout out to Lee, who's with Dellum watching from Connecticut. We see you. Thank you so much. And, I'm a big advocate about information is power. No one should go into their doctor and leave and go, I don't know what he said. I don't know what she said. Either you're not, go back and say, you know what, I'm not ready to do anything until I get some more information. That's okay. You should be giving your patients literature. You should lead them to the internet. I have patients who speak Spanish. I have things in Spanish, and I also speak Spanish. So that's all my patients, to make sure that they understand it. And even sometimes I tell people, bring a family member. so we
Yes.
can have a conversation, particularly if English is not their first language, to make sure we're all on the same page. And I have bilingual staff, so I even have my staff member in the room, so we're all on the same page. But I think that even your family member or your cousin or your friend understanding, making sure that y'all are having the same conversation. In my consent, I have a part, I don't know if you ladies have it, where say in your own words, if you were talking to someone, what this means. That's a proof of competency to me, number one. And number two, that you truly understand what you're getting yourself into. So I'm very patient heavy in terms of understanding before we go in. I explain it 50 times in there. I have videos. I have a board that's like a patient education board that pulls up the foot in 3D, and I can draw on it. We go over the consent again. By the time we're at the hospital, they're like,
We
by the
talked
time the
about
resident
this.
comes,
Yeah.
yeah, yeah, I got it. And I laugh, and I'm like, nope, you go prove to the resident that you understand it as well.
We're going to do it again. Yep.
We're going to do it again, as they say. So, yeah, I'm very patient heavy. I think that's the best way to make sure that someone knows what they're getting themselves into. I'm also not opposed to, I've done surgery on 80-year-olds. People think that age will preclude you or prevent you from having surgery. It does if you're a broken up 80-year-old and have a million medical problems. But if you're stable, and you're healthy, and this is the problem, I fixed it, and the patient's been, oh my God, doctor, I can wear my shoes comfortably. Thank you.
Yeah, we just want to keep you active and healthy, really. I mean, there's different types of 80-year-olds, just like you said, right? There's the ones that are like my mother. She's not quite 80. She would be upset to hear that. She's a little
Sorry,
younger.
mom.
Sorry, mom. But she's enjoying her retirement, enjoying her grandchildren. She goes to the gym every day. She's healthy and fit. And then I have people that are the same age as her that they are relying on others to bring them to their doctors. All they talk about is their medicine and their ailments. These are usually the people that are not very good candidates at 80 plus years old to have any type of elective foot surgery. But for those who need it and who can, it's life changing, and it gives them back, the ability to wear shoes comfortably and to remain active for the rest of their lives. So I don't shy away from age either, as long as they are in good health. Absolutely.
Absolutely. Age does not prevent you from surgery necessarily. It can, but it isn't always happening. Dr. Nafor, what are you talking
Yes.
to about your senior patients? Because I don't
Yeah.
call them geriatric, they're senior and seasoned.
Actually, I had a 90-year-old patient begging me to
Wow.
do a surgery because the toe was so badly rotated, meaning that it's crooked and sitting on top of the other toe. And she could not wear any shoes. And I was very hesitant to do surgery on this patient. I'm like, she has been with the same deformity for so many years. And then on top of that, she was blind also, legally blind. And I was like, I really don't want to do it, but she begged me to do it. So I end up doing both the Hammertoes and the bunion. For the Hammertoe, actually, I use the K-wire model to fuse, like to hold it in place. And the bunion, I decided not to do any osteotomy, like cutting the bone and shifting it up. I just shaved the bump. I wanted to take the very safe route, like a route for this. And to tell you the truth, intraoperatively, her bones were like stronger than most of the 50-year-old patients, and she ended up healing very well. But one thing that I wanted to add to the conversation is that we have to take in account also the patient's occupations and where they live, because these are things that come along when we're doing surgical procedures on patients, because some people think that after the surgery they can just get up and go and walk around and do all the different things that they need to do. And
Tell me about it. I had a friend I did it on, and she went to the mall and then
yes,
called me like, well, girl, I know you got medicine at home. What? Okay. You went to the mall.
yes.
I just did your surgery in the office earlier. Well, girl, I had to go pick up something. And I'm
Yes.
like, okay.
Yeah. And when they have stairs, also they have to go up the stairs and all of those things. So we have to plan our surgical procedure according to their living arrangement. So these are things that I want to bring up so that people are educated about this, because patients come to us, they think that, okay, surgery today and tomorrow, but it's so many other things that take effect.
Lifestyle.
And you need to are you willing to stay out of work for a few days, few weeks, for the bone to heal? Or do you have a standing job where you're on your feet all the time? Or do you have a sitting job that you can actually sit at your desk and keep your foot elevated? So these are things that I wanted to add in so that the public are aware of that.
Absolutely.
Also, how about like making sure that they don't have any like vacations coming up or like special events and they're in such a hurry, like, oh, I need to have this done before, I go on this cruise.
Yes.
One time I had a lady who I didn't have that conversation with many, many years ago. Now it's part of my conversation because of course you learn. She had 3 weeks off from work for a bunionectomy. So she decided that she was going to go to Italy and be on vacation for 3 weeks while she was recovering. When she came back, that bunion was a mess and we had to redo it. So that's also super important to talk to people about, like, hey, you need to be close by. There's weekly checks after surgery. You need to come in. And then one other thing before I forget, I don't know if you guys think that this is like extreme or if you've ever done this, but a handful of times in that 90-year-old who you're talking about with like a severe hammer toe, I've actually done elective amputations for hammer toes.
Yes.
Have you guys done that too? It works so great.
So
it works so great. And
they
it's
do.
really
and
just
people
easy.
think that, right? So people, in case you guys are like amputate, occasionally amputation is, because I know that they're looking at us like, what okay.
I know.
Sometimes
but
an amputation or moving the toe is necessary. The toe is too far gone, or the healing may not be great because the circulation may not be that great versus taking it off, or circulation may be better in the medial part of the foot. And that's an option, usually reserved for patients with poor circulation and our rheumatoid arthritis patients who have these rheumatological diseases. Rheumatoid patients look like this, like they're clawing at you. And a lot of times we're trying to correct those toes so they can fit in shoes and that they don't feel pressure on the ball of their foot, because they will start to form open wounds there that becomes very uncomfortable. And so
bunions,
amputation is always on the table for those types of patients, in addition to the things that we said. And you're right, Dr. Sutera and Dr. Napor. Let's talk about healing. I tell patients, listen, you have them stitches in for 2 weeks. Don't ask me about it. We're not moving about it. Good luck. Go with God. That's my favorite thing to say. Number 2, you need to elevate your foot. Your foot's not elevated by chilling on a chair. Your foot is elevated when it's at the level of your heart. If it's not, it will swell. Number 3, time of year, particularly in the Northeast. When we get hot, especially my Southerners, your foot will swell. It will swell. Okay. Sometimes a cold, you might feel more pain because it's so cold outside. So you also have to tell people, when they're thinking of doing it, what lifestyle. Obviously, if you can get into a sandal in the summer, obviously coming out of your post-operative shoe or boots a lot easier than someone who may have to only be wearing an UGG or a clog or something of that nature. And that also contributes to when and if we'll do it and what their healing looks like. And I tell them swelling it's based on time of year, type of procedure, how active you are, your weight. And I know that weight is a big thing now, the GLP-1s, but your weight, that's another issue. And how active you are. If you're running to get to Subway after, you're going to have some swelling for a while versus someone who may be working from home and has no issue. So we try to keep all those things in account. Ladies?
Yeah, that's basically what it is. I basically tell my patients the same thing. Elevation is key. I tell them the first 2 weeks, I don't care what you're gonna do. You're gonna have to cook before prior to the surgery. Stock up your food in the refrigerator, in the freezer, so that you don't have to be on your feet at all. Because the key to this incision to heal, where we make the stitches, is to have less swelling. The more swelling you have, the more likely the longer it's going to take for the wound to heal. So I tell them you have to elevate that foot. Like we said, above the heart, like at the heart level. You want it to be higher. They'll be like, but I'm elevating my foot. And it's just like down on the chair.
I make them show me.
You got to put pillows and elevate to take the pressure off. And sometimes patients who have circulation issues, for example, I tell them summertime is not the best time for them because we get vasodilation. The vein expands and then they can end up having more swelling. So I tell them if they want fall or springtime seems to be working for a lot of patients. So most of the time, a lot of the patients who have those issues, we try to aim their surgery at that time.
Very cool.
Keep your,
Oh, go
oh,
ahead. Sorry, Jackie.
I was just going to say, keep your scar protected from the sun for about a year. You know, you don't want it to turn darker or like permanently, you know, discolored. So SPF or bandages or even shoes that will cover, you know, your scar if you're going to do that dorsal incision. I also like to do some of those cosmetic ones on the side,
Definitely
which,
do.
yeah, you know,
But it's not for
with,
everybody.
it's
Realize
not for
that.
everybody.
Sometimes
Absolutely
if your
not.
hygiene is poor, and we have patients,
Oof.
they sweat a lot.
And
And I'm like,
what about people that have tinea? You don't want
right,
to
that if you have
incise
acne
into
foot
that.
chronically in between your toes, you're not a candidate either. So it's
No,
not always for everyone. It's for patients that match the description that we
of
need.
course, of
And
course.
one of the things that I like to do, also talking about scarring, is that I usually give a injection of a steroid, and a subdermal, which means right under the skin, and I bandage them to try to reduce some of the inflammation. And then once the wound has healed enough where I feel you're safe, I love telling people, I love shea butter and vitamin
Yeah.
E. I make them put it in a blender, whip it, and I make them wax on, wax off, and massage that scar. And I tell patients that that scar can take up to a year to show what it's going to look like. But if we're using the properties that are found in those products, which have collagen and vitamin E, A, all those great things, then the scar will look as well as it can be. And I've had patients quite pleased, like, you were right, 6 to 8 months later. I'm like, yeah, you did what you were supposed to do as well. And we're both happy at that point. What do you tell your patients for post-operative scarring?
For scarring, I definitely, like I just said, I want them to stay out of the sun like that. I definitely tell them not to pick at the scab. So
Yes.
after 2 to 3 weeks, when those stitches come out, a lot of times, like the marker, the purple marker that I use to draw my incision, it's still there. And all the little like bloody, crusty scabs, like I can see past all of that. And usually I'm like, wow, this is going to look perfect, but do not pick at it. You can introduce a bacteria, you can create a wound, you can open up an incision that is not fully healed, and then your scar is going to be crazy. I mean, once that scabby stuff falls off naturally, when the body is ready to shed it, underneath should be a perfect little beautiful line, or on the side should be a perfect little line. So don't be so quick or anxious to like remove that stuff. You don't need to use an exfoliant. You don't even need to use a washcloth. Just let it fall off. So that's like a big thing, because I do want it to look nice. It's not just about the function of it, but of course I care about how it looks. I think that just adds to the overall success of the surgery and how happy your patients are. So I don't want them to mess up my incisions.
Yes.
Absolutely. Bijou, what do you say to your patients?
So I basically tell them the same. I tend to do the type of closure sometime to minimize the scarring. So I use Proline for all my patients who are like dark skin. I don't use monochrome for
hold
anybody.
On. These people just said, she said, what's a Proline?
Proline. So basically it's the least reactive suture that we have over there.
Stitches.
Don't cause you to have swelling, more watery, like it doesn't break under the skin and cause you to have more scarring. So that's what I use for all my patients. And then also for the Hammertoes, I try to, the incision type, I mean the closure type. So I try to slightly invert my my suture when I'm closing.
What does that mean? Because I know
oh my God, that's what I was trying to say.
So I'll even break it down for you. So sometimes
it's a technique.
It's a technique.
It's a technique that like we use to.
We do this a little bit to have the skin part just a little bit up, a little bit
coming out, so that when it heals up, it's gonna flatten itself up, and therefore your skin will be nice and smooth, and you're not gonna have this thick scarring. So those techniques has worked for me. Basically, I use those techniques. They have worked for me very well, and then my patients tend to do very well, and they're happy with the scarring. And I tell them immediately when we take the sutures out, I'm like, start putting vitamin E oil. You don't have to buy any of those big fancy scar gels that they have out there. there. But if you feel like you can go Mederma and the other collagen products that they have out there, you can put them on. But I tell them, take the capsule. If you can find the gel, the liquid, just open the capsule and put it on the scar and it will heal just fine. So
Absolutely.
that's what I use.
Absolutely. I agree. I think that technique from your doctor is a big part of it. Just giving a shout out. I see Dr. Labrina Bryant, who was one of our former guests, saying hi from
Yay.
DC. Hello. Um, technique. Also having a great relationship with your doctor. Your patients, you're married to your doctor for a period of time. You're going to see them. You're going to see them. You're going to see them. I like to be in your business, because I want to know what you're doing as well for the healing. So, if you tell me, I have patients who be like, okay, doc, I want to go to church. So can I go to church if I wear clogs, if I wear this? And I always say, okay, are you singing in the choir? Are you, I'm getting in your business is not for me to be nosy per se. It's to
Yeah.
let me know how much standing are you doing? How much sitting are you doing? So we can tell you that. And a big hi to the Touch the Black Breast Cancer Alliance, which I've spoken for as a patient and as a doctor, my dear friend, CEO. I love her to death. I know she's on, Ricky Fairley. Thank you so much. They precede us with a great show for anyone who's affected by breast cancer, both men and women. Fabulous show that comes on weekly on Wednesdays at 6 p.m. So giving them a shout out. So I think that having a good relationship with your doctor where you can talk to them and tell them expectations, things coming up, how can we tweak some of these things? And we want you to still live your life just safely so that, no one is having a problem where, oh my God, my toe is swollen, or I've ripped the sutures, or my toe is crooked again. We see lots of that. I have a lot of patients who have had surgery years ago, right? Jackie and Bijou, who come in and they're like, I had this done 5 years ago, 10 years ago. And I'm like, well, here we go again. So hello to Michelle West. I'm seeing so many people. Hello to Janice. I think I'm saying your name right. Fantastic. Hi to Robin, one of my faves. Thank you. Hi to Mimi. Thank you. Yeah, congratulations, Mimi, on the breast cancer survivor. We saw that. Fantastic. So what I want to know as we're closing, as we come to a close, you are, and where are you? How do we find you? Because patients are like, oh, this was nice. How can we find these doctors? So tell me, we'll start with Dr. Napur. Where can we find you, both on social media if you have it, and also live?
Website, Google. Just type in drbijounuforpodiatry.com. You'll find me right there. And it's on my card. You Google my name, I'm Vernon, and you will find me right away. I'm one of
Bijou
the,
Napur Podiatry. Let's slow that down.
oh,
Podiatry.com.
drbijounuforpodiatry.com.
Okay. We got you. And we can find you on social media.
Yes, I'm not a very big social media person, but you can find me in the website only. I don't do social media like that. But
No
they have an
worries.
Instagram. My patients are trying to encourage me to put in other stuff, and
We'll
I'm
get you there. Don't worry.
finally getting there.
We'll definitely get you there. Dr. Sutera, Jackie, where can we find you?
You can find me at citypodiatry.com. You can find me at on my Instagram page at Dr. Jackie Sutera, on Facebook. So City Podiatry and Dr. Jackie Sutera have two separate entities there on social media, and also my website, citypodiatry.com.
Fantastic. And you can always find me, Dr. D, on all things with Talks with Dr. D. A plug, besides, talking about podiatry, Talks with Dr. D also has our medical symposium that is going to be a fabulous event on the Vineyard, August 13th at the largest mansion known as Dempster Park, with our keynote speaker, Sunny Hostin from ABC's The View, and also our guest speaker, Malik Yober for New York Undercover and Empire. And we're going to be talking all things health, wealth, financial literacy, and empowerment. So if you go on my site, Talks with Dr. D, you will find all that great information. You can find me through there and questions at any time. This has been amazing. I love educating people. I think it's great. It's questions. We're here for you. Feel free to reach out to these doctors. They respond. Those who live in the tri-state, feel free to find them. This show is a monthly show that comes on the first Wednesday of every month at 7 o'clock. We delayed today because obviously last week we were celebrating 4th of July for those who do, and people were away. So we wanted to make sure we had a great audience. We're very thankful that you've reached out to us, and we appreciate it. If you need anything and you need more information on these ladies, feel free to find me, again, at talktoDrD.com. And you know what? I love it. Jackie, we've known each other since, we're not going to put that out there. Since New York College.
It's been a while.
It's been a while. Mind your business, everybody. And Bijou, I mean, it's been amazing. You're my resident. I remember I put you through a difficult case and you were like, oh my gosh, she's going to kill me. And I'm like, you're absolutely right. I am. And you did, you remember it to this day because I tease you still about it. And you did fabulously well in now in private practice, which makes the profession and myself quite proud. So keep doing all the great work, ladies, that you're doing. These ladies are here for you. We're here for you. Next topic is a secret I always post, so you have to look out on my social media to find out what it's going to be. And I have a variety and a diversity of different hosts because I believe that's what gives us the best information. And what? Power is knowledge. I thank you so much for joining us, stepping forward with Dr. D on blackdoctor.org, where what? Culture and connection meet. We thank you and have a wonderful, wonderful evening.
Thank you.
Yeah,
have a good night.
Bye.
Bye.